Well, good evening, everyone. Thank you for joining. This is Ashkan Lashkari. We are here having our monthly panelist chat moderated by Dr. Hatim Husain from UC San Diego. Today, regarding our lung cancer session, we're going to be doing things a little bit differently and having kind of a group discussion with a few panelists that we're very excited to have here. And the topic will be discussing novel therapeutics in non-small cell lung cancer. Dr. Husain, I'll pass on the baton to you.
Thank you, Dr. Lashkari, and it's really a pleasure to be here and speak with you all today. I think part of the reason why we're excited about this, and again, we've been doing these webinars now for almost completing a year, which is a great milestone for us in a way. And we wanted to kind of have some final, reflections and caps around, what we view as important areas forward in lung cancer. We actually have, the great fortune and pleasure to have a very esteemed panel today of truly leaders in lung cancer, leaders in novel drug development, leaders in clinical trials, and also, perhaps, having a lot of experience with the medicines actually that we may be speaking about. So, as first introduction, the group well knows Dr. Garon, really a leader in lung cancer as a whole, and really pioneered some great, kind of benchmarks on how we think about even how to optimize chemotherapy, and VEGF strategies, immune therapy, with some of the seminal work in PD-1, and also, moving forward in many other areas of lung cancer as a whole. And then Dr. Borghaei, who is a leader as well on novel drug development, immune therapy, and really all aspects of lung cancer. And then also Dr. Aaron Mansfield, who will be joining as well, who is also a great KOL in lung cancer, really kind of great person to kind of speak with as well on this panel. So really looking forward to the discussion. And again, actually, I know that Dr. Borghaei has also just joined. The way that we are setting up this discussion is one to think through, where are the hot topics in lung cancer? Where is the field actually moving? What do we as a panel feel like are the projections forward about what may be the best kind of up and coming strategies or areas for further exploration and knowledge and education? And some of these I will kind of introduce, and really it would be great to kind of hear about individual thoughts and kind of projections forward in this space. So the topics actually that we're going to be dissecting are antibody drug conjugates, some reflections on checkpoints and kind of what may be emerging checkpoints, or kind of where are we at with regard to our reflection in checkpoint inhibition. Now recognizing too that we have FDA approval for PD-1 and CTLA-4, perhaps another FDA approval for CTLA-4, kind of the field is trying to understand where Poseidon, the clinical trial that looks at durvalumab and tremelimumab, fits. How do we think through the PD-1 story, either in combination with chemo or as monotherapy? And then how do some of the other novel checkpoints, such as TIGIT and LAG-3, factor in? And how do we think through what may be the right subsets or groups that may derive benefit? And then lastly, some other kind of emerging approaches, whether they be bispecific molecules, and there are some molecules that can bispecifics against PD-1 and CTLA-4. Also TILs or tumor infiltrating lymphocytes, where do those factors fit? So with that, actually, I wanted to share just a few slides just to set the stage and to think about where some of the new approaches are. Some of these are actually from recent meetings. And in fact, actually, I thought even just best is to kind of present the exact slides that were presented at particular meetings for reflection. But I think kind of the goal of this, and again, the goal of this is to really understand how we think through where the field is moving. So that's kind of what one of the, the big projections forward. So let me do this actually is I'm going to first kind of share my screen with regard to recent slides that were presented at World Lung. And this is particularly in the context of a study known as Poseidon. So again, so this was slides that were presented by Solange Peters. And particularly, actually, the slides here were looking at a reflection of the Poseidon study, which is durvalumab and tremelimumab and chemo, kind of looking at certain biomarker selections and approaches. But I think we're going to look at this through the lens of where does the field sit? How do we need to define things and go forward? So with that, actually, I think kind of it's important that we understand the study design. Poseidon was, again, CTLA-4 plus PD-1 plus chemo versus chemo alone, or chemo plus durva. And again, patients were continued on therapy. Primary endpoints were PFS and OS. It is important that patients were included irrespective of PD-L1 across both histologies of squame and non-squame. And, this number of cycles of chemo are 4 cycles. I will take a pause over here, just to kind of get some reflections, from you guys about now when we think about Checkmate 9LA, firstly, actually, maybe Dr. Garon, I'll turn to you. Have you had a lot of experience with Checkmate 9LA? And the next kind of points is how do you view perhaps kind of a new regimen coming into the picture in light of that?
So I don't have a lot of experience with Checkmate 9LA. I am an author on Poseidon, so more experience there. The interesting thing from my perspective, and maybe being a little harsh on myself and my colleagues in this, in that I as I say, I am an author on this, but I think that people who sort of make their living largely treating patients have a right to be a little upset with some of those of us who spend a majority of our time focused on research, in the sense that we've randomized at this point thousands of people to studies looking at CTLA-4 inhibitors, and we still can't tell people in practice the simple answer to how much, if any, does adding a CTLA-4 inhibitor to a regimen that otherwise doesn't have it, what is the benefit there? And I think that's been really a disappointment of our study designs that we have had to this point. And unfortunately, Poseidon doesn't answer that. Now, of course, it's a little unfair in the sense that you can't know what a study is going to show until you run it. But as you go through this data, and of course, 9LA is a little bit different in that there was no nivolumab chemo alone arm. But even when you have, for instance, the Checkmate 227, we sort of keep getting ourselves into this problem that we can show the benefit of a CTLA-4 inhibitor containing regimen, but can't necessarily isolate the benefit of the CTLA-4 inhibitor, which I don't know what the others' opinions are, but from my perspective, it is a failing.
Yeah, that's a really interesting and astute point. Dr. Borghaei, I may actually turn it to you, actually. How do you view and use CTLA-4 in lung cancer now, and kind of where do you feel like that is most advantageous?
First of all, thank you for the invitation and for arranging all of this. Can you hear me okay?
Yes, no, perfect. actually.
Yeah. So I think I absolutely agree with Dr. Garon that we haven't done a good job of identifying the patient population who truly benefits from the addition of a CTLA-4 inhibitor to the regimen that we're using to treat the patient necessarily. So having had the ability to develop a biomarker for this particular treatment would have been very, very helpful. And I also agree with them that there's no way for me to tell you who specifically is going to benefit from the addition of a checkpoint inhibitor, like a CTLA-4 inhibitor, I should say, to the treatment and algorithm, just again, because we just don't have that ability. However, what I have done in my clinical practice at this point is that, contrary to Dr. Garon, I use the Ipi-Nivo combination actually quite a lot. Now, just like Dr. Garon is an author on the Poseidon, I've been the author on the 227, and I'm obviously a little bit biased towards that regimen. And what I have done in my clinical practice is that I have incorporated the Ipi-Nivo combination, and to be honest with you, mostly the 9LA type of a regimen. I can explain why. To my clinical practice, specifically in patients with PD-L1 negative tumors, because I think if you look at some of the long-term data of the 227 in the PD-L1 negative tumors, that sort of the tail of the curve is a little bit better than with a typical chemo-IO combination. Obviously, we don't have head-to-head comparisons, and it sort of becomes interpretation of the data the way you see it as an investigator. But that's what I've decided to do in my PD-L1 negative, particularly the squamous cell histology. Now, the reason I like 9LA, even though I'm not an author on 9LA, didn't participate in 9LA, is that I always thought the chemo in the beginning could give us a little bit of a protection against early progression. And I think that's what we see in the progression in the PFS curves for 9LA. So using 2 cycles, most of our patients are able to tolerate the 2 cycles of cytotoxic chemotherapy. You avoid that early progression. You might be getting some additive benefit, I guess, from the checkpoint inhibitor being added to the combination. So that's the way I have interpreted the data, and that's how I have incorporated the Ipi-Nivo into my clinical practice.
No, really great reflections. And actually, Dr. Borghaei, I may actually ask you, a quick bit of advice here, is because so in my clinic today, I had a patient who had completed the 2 cycles of chemo and Ipi-Nivo, and we had gotten a scan, and majority of her tumor had shrunk, but there were a few lesions, one lesion in particular in the liver, that looked a bit bigger. And her question to me was, I've completed these 2 cycles of chemo. Would it be a good idea to continue the chemo in addition to the Ipi-Nivo that, continues as the maintenance approach? The reason why that comes to mind here is because as we see the schema and we see the 4 cycles of the chemo, I mean, how do you view the 2 cycles of chemo? Are you comfortable with that 2 cycle component? Do you feel that for some patients extending the chemo is particularly important? How do you view where the field should be in that regard?
It's hard to know, Hatim. I mean, it really isn't. It's not an easy answer. So you follow the clinical study when you decide to use a particular regimen for the treatment of your patients. So in my view, if you sort of interpret the data as, let's say, the 9LA or this Poseidon regimen is the way to treat your patients, or at least a good option for some of your patients, then my impression is that you should follow what the protocol has done, because that's what the best result is. And in other words, I'm using 9LA because I kind of like the result of the 9LA. So if I want to come in and now tamper with it and make it my own personalized 9LA, then I'm deviating from the trial. So to some extent, that's how I interpret the data, and that's why I am comfortable with 2 cycles. That being said, there's nothing wrong with the the clinician anywhere to say, look, I'm getting really good results. The patient is tolerating. And even though it's not the way the study was done, since the patient is benefiting and tolerating without harm, maybe we want to continue. So I'm perfectly okay with that kind of a strategy, as long as we realize that we're making things up at that point, because the data says 2 cycles and you should be good. But if you're having that great of a response and you're nervous about dropping the chemo, I think it's perfectly understandable to continue it. Again, the patient should also be aware that there's no safety data for continuation of 4 cycles of chemo, at least with an ipi-nivo regimen. If you're doing the Poseidon, then you have more of a sort of a safety data also to go along with the efficacy and the way the study is done. It all depends on how you interpret the data. And then I see that in the bottom that you have the CK11 keep 1, and all of those are going to become factors to sort of consider, and hopefully we can discuss that. But in my view, yeah, you had 2 cycles, a great response. I would still say follow the study and sort of see what happens from there.
Really good reflections, actually. And, I wonder if this 2 or 4 cycles is going to be somewhat of a consideration about how people select available regimens if, say, Poseidon was available, and I do think that that's kind of an interesting scenario. I may ask, actually, I feel truly honored that I have investigators from actually both of the 2 regimens around with regard to ipi-nivo or durva-tremi. Do you feel like there's actually a difference in the, CTLA-4, meaning how different is tremi from ipi?
Are you asking me or are you asking Dr. Garon?
Actually, both. Actually, I feel like such a great opportunity here to ask you to get these questions.
Well, let's see what Eddie thinks about this. Eddie, you go ahead first.
Well, first of all, I mean, tremelimumab is a fascinating drug. I was at UCLA. I was at a talk with Tony Ribas the other day, and he talked about his initial studies with that drug that were about 20 years ago. So this drug has been in development for decades and has, I think, maybe got approved for the first time this week, along with durvalumab for hepatocellular carcinoma. So one of you can tell me if I'm wrong on that, but I think that was its initial approval after really 20 years, I think, of research on the agent. They are slightly different antibodies. I think the answer is it's very hard to know, just like it's been very hard to know on all of these. The one thing, and this is, sort of remains my complaint with the CTLA-4 inhibitors, we don't know what the role of CTLA-4 inhibitors are in lung cancer. We've never shown an individual benefit. We've never sort of proven the components issue. So I think it's very hard, at least in lung cancer, to answer that question. Now we know in melanoma, the winner ended up being ipilimumab. I don't follow the melanoma literature well enough to know whether that was a strategy issue or having anything actually to do with the drugs.
Really great points. Thank you, Eddie, for sharing those. Haas, actually, any thoughts that you have there?
No, again, very similar. I think to what Eddie said, the drugs are clearly different. I think ipi has some single agent activity in melanoma. Obviously, we didn't try it or maybe it was tried in lung with combination chemo. It didn't really quite work out quite as well. So there are some slight differences between the 2 drugs. But in terms of, is one better than the other and all that, I really won't be able to tell you. And yeah, I'm aware of the fact that actually both ipi and tremi have been under investigation for a couple of decades before they really got into clinical practice and got to a point that we can talk about them as part of being sort of incorporated in some of these lung cancer studies. I think we do have to point out that the doses of both drugs that we're using are a little bit different between disease sites, and obviously for ipi, it's a completely different dosing and schedule in lung than it is in a melanoma, or I think even renal cells. I think we we're very sort of cognizant of the fact that toxicities with this drug is real. In Poseidon, it's basically, I think, 5 doses of Tremi, and you stop. In 9LA and with 227, it was continuous treatment every 6 weeks. So those sort of developmental strategies and dosing and all of that obviously becomes an important consideration in all of this also.
Really super helpful. And, you know, I see that Dr. Mansfield is here too. You know, thank you, Aaron, for joining. What we've been discussing so far has just been, you know, where are we at in terms of some dual checkpoint strategies? And part of the focus here is also going to be, you know, some forward thinking about, we had other agents, let's just say LAG-3 or TIGIT, you know, how would these things also even apply? And so, you know, just to kind of finish this off, so this was data presented at World Lung, you know, some subgroup analysis really looking across a variety of different mutations, and in particular STK11, KEAP1, and KRAS. You know, Dr. Borghaei, you had mentioned the point that, you know, the field has become quite granular. It's not enough just to say an EGFR positive patient anymore. We're really understanding, you know, which EGFR mutation, now in this context, some other unique biomarkers. I think what's curious about this is that the overall survival by STK mutation, you know, seem to look a bit different on these Kaplan-Meier curves, with you know, 2-year overall survival improving with the addition of Tremi in the STK11 mutant patients. Seem to kind of correlate with PFS and some element of ORR as well, with some median duration of response. KEAP1 also a bit, you know, a bit different. KEAP1 data isn't so clear though, and you know, as a whole, you're really kind of going through this across mutations could be important. Here's the data for KRAS mutations for overall survival with the Durva, Tremi, and chemo versus not. So I think kind of just, you know, reflecting on this, and actually Dr. Borghaei, I may mention this and ask this of you, you know, in this way, because you did point this out. Do you feel like there is a difference with mutations? And are we going to need to kind of know about these and input these into our thinkings as we use these medicines?
Well, I'm not using these to make a clinical decision as to whether I should give IO or not yet at this point. The data that we've talked about and generated so far are really retrospective. So the data that you're showing is a subgroup analysis of a subgroup of patients in a large randomized phase 3. So you're already talking about a small patient population here. But it adds to this growing information that we're gathering. I don't think it's noise anymore. I think it's gone well beyond being just noise. I think this is real data that KEAP1 and STK11 could, to a great extent, diminish the activity of single agent IO. Even in some cases in combination with chemo, the data doesn't seem to be very supportive of IO doing much when you add it. Again, we need prospectively designed studies to really evaluate these. I think what you show here based on the Poseidon data is hypothesis generating and goes along with the impression that we've been getting from other studies, our colleagues from MD Anderson and Memorial publishing extensively on this, again, suggesting that particularly KEAP1 mutation, which, you know, thankfully is not that common, is something that's going to cause us problems when we're using single agent IO. So this data will tell me that based on just basic PFS and OS, that maybe there is something to the combination of a CTLA-4 and a checkpoint inhibitor. Here, obviously, is in combination with chemo, that might make these tumors a little bit more responsive to, again, the combination of 2 checkpoint inhibitors. It doesn't prove anything. It doesn't mean that we should run into our clinics and identify these patients and offer them the Poseidon regimen necessary right now. But I think this is something that we need to investigate in a nicely designed prospective study. I think I am somewhat happy or impressed by the spider plots that you showed with various mutations, because some of these patients do seem to have really durable responses. And some of them might not necessarily hit resist identified like partial response, but you get 15-20% reduction and you maintain it for a while. And I think, again, the story is developing that maybe for some of these alterations, we need to have a different strategy than just chemo IO for everybody who walks in through the door, if we really want to help a patient population with these particular mutations.
So really, really great insights. And to, I may ask actually Dr. Mansfield, kind of jumping into this discussion a bit, firstly, actually, what has your practice pattern been regarding checkpoint inhibition, perhaps dual checkpoint inhibition? Do you use combinations of CTLA-4 often?
Less so. We've primarily used the ipilimumab and nivolumab combinations for patients with the low PD-L1 expression who've wanted to avoid chemotherapy. So more in line with the Checkmate 227 data. That's been the majority of our use for non-small cell lung cancer. For mesothelioma, which isn't the topic, that's our new frontline standard of care. Really, we've been trying to find a home for the 9LA data, and I don't know if I know the exact subgroup that's best for. I sort of liked the idea of we'll do chemo light, but so to speak, only 2 cycles, but I still think you get the full toxicity of the quadruplet when you use that. And that's been my experience to date. So our primary use in non-small cell lung cancer is for the lower PD-L1 expression, wanting to avoid chemotherapy for patient preference or some contraindications to cytotoxics.
And if you were to estimate just the number of new chemo IO starts, that you've had, kind of perhaps, this year or so, kind of what percentage of those would have been IO plus chemo? Like meaning CTLA-4 PD-1 plus chemo?
Yeah, I think between 227 and 9LA, it's probably 10% or so. Okay. It's just ballpark, top of my head number.
Super helpful. I think it gives us insight into, just kind of where, kind of how diverse are the practice patterns here, kind of where are we all at with additional agents coming into the picture. What is kind of, say, the enthusiasm of expanding that, for CTLA-4 and such. I may actually, continue to ask you, Aaron, just this other point is, so let's just say that Poseidon kind of comes about and gets approved, would that in any way enhance or kind of expand your CTLA-4 use?
I would need to think about that more, maybe. Mm-hmm. It would be another option to consider, and I welcome more options, but how do you tease out who's going to benefit? Haas just really covered these subgroups really well, and right now, as I see it, a lot of these subgroups are more intriguing or hypothesis generating than clearly hitting the nail on the head that this is exactly where we should use this regimen. So right now, I don't know where in the spectrum of patients we see that it adds to beyond the existing regimens we already have.
Really great. Thank you, Aaron, for sharing that. I do know also that, you had, in a prior time kind of made it a point about the IgG subclass, subtypes and kind of potential differences. Any insights you want to provide in that regard about CTLA-4?
Well, yeah, and again, my apologies for joining late mid-discussion, but I had a conflict until a moment ago. With the, I do think one thing that's intriguing is ipilimumab is an IgG1 subclass, which has a more potent antibody-dependent cellular cytotoxicity, whereas tremelimumab's an IgG2 subclass where there's much less ADCC potency. Mm-hmm. And then some of the preclinical work suggests that the CTLA-4 antibodies with the ADCC capabilities can actually deplete some regulatory T cells. And I just think it turns our whole understanding on its head as to what we're actually targeting with these drugs in terms of what cellular subset of the immune system here. And does ipilimumab really help by depleting some regulatory T cells? Just some of the work Dr. Quezada has presented has just challenged my thinking as to where this drug is working in the body.
No, thank you, Aaron. Super helpful. And also, I think that, perhaps highlights the fact that as oncologists now, currently seeing patients and trying to understand the best avenues forward, layers of granularity are important now, and I think we had discussed kind of the molecular granularity, across even some genes that we don't typically think about or talk about, such as KEAP1 and STK11, then perhaps even also kind of understanding how the subtypes of immunoglobulin also can be important in terms of inducing ADCCs, other cell death mechanisms. So now for a hard question, kind of for all members of the panel here, is, there's emerging data in other checkpoints, right? TIGIT, LAG3. How do you guys view these other checkpoints? Do you feel like there is, say, a home run in another checkpoint that is still outstanding that we have not brought forward? Kind of where is the field with regard to checkpoints? Is there going to be expansion, you think, in the way we think about lung cancer here? And actually, maybe, Eddie, I will turn it to you first, actually, just to kind of get your thoughts. And again, anything you can share with us would be helpful here.
Yeah, well, in terms of sort of home runs of the other checkpoint inhibitor, even though I'm now in a big market here in LA, I grew up in Minnesota, and we sort of learned that if we had a home run hitter, pretty soon he'd end up on the Yankees. And so the Twins sort of generally learned how to put together wins with strings of singles, which is okay. I think we have to recognize we don't hit home runs all the time, and that I don't think any of the data we've seen from any of these are the home runs we saw with nivolumab or pembrolizumab. And in fact, I'm always hesitant to talk about Haas's study with Haas, on the call, but oftentimes when I talk about drug development, his study is the one I use because the Checkmate 057 study, to me, that's a transformational study, okay? You have a therapy, which was single agent docetaxel, which people didn't think was very good. And then you had another therapy that after you saw the data, no one would ever think of, unless you had additional data, to put someone on docetaxel rather than nivolumab. The hazard ratio for survival from that study was 0.73. And so we tend to design a lot of our studies now for these hazard ratios of 0.65, 0.63. And to me, it's absurd because when we hit a home run, that isn't what it looks like. And so I think that we have to accept that we're not going to hit a home run every time up to bat, but that singles are good enough. But you need to sort of be more thoughtful about them. You need to, if you're going to be hitting singles, you need to figure out your batting order. You need to figure out who's going to hit behind who, so you can get a bunch of singles in a row to score a run. And I think we have to be more thoughtful than we've been since that, when we combine things, so that we really can tell what's the benefit of our studies, so we can design studies appropriately to answer the questions we have.
Excellent analogy. In fact, actually, I think that's such a astute kind of way to synopsize what we should be aspiring to. Has, I may actually ask you, what do you think about these other data sets, LAG3, TIGIT, and speaking to Eddie's point about being more thoughtful about perhaps sequence or strategy there, what is that combination?
Yeah, I absolutely agree. So I'm going to follow his analogy, since the Phillies are in the World Series, and that's the last team anybody thought would make it to the World Series. Just to show you the power of having those home run hitters, when you have a string of singles that that go along with it. So look, I think I'm actually a little bit worried that the momentum we gained with all the early studies is beginning to dissipate a little bit. And it really does worry me. I agree that we cannot expect hazard ratios of 0.6 and 0.5. We're not going to do ADORA type studies with a hazard ratio of 0.2 and 0.3s anymore. I mean, in a metastatic setting. And I think we do have to be reasonable. I absolutely agree that we have to learn how to use some of the drugs we already have better. And for me, at least, that's more biomarkers, more patient selection, identifying who really is going to benefit from the drugs and combinations that we have, as opposed to giving it to everybody who walks in through the door the way we have been doing it. That being said, I think of the checkpoint inhibitors that you have mentioned, I'm still hopeful that TIGIT will give us, at least in a particular group of patients, a little better overall survival outcome. I really feel like that is possible. LAG-3, I think it's an interesting pathway. There between LAG and TIGIT, we might be facing the decision that maybe some of these newer agents work better with a PD-1 as opposed to a PD-L1, and vice versa. I think that story, if you look at some of the preclinical data, might be developing already, and hopefully will translate in the clinic, which goes back to what Eddie was saying. We should learn what we have and learn how to use it appropriately. Maybe a TIGIT would do better when paired with a PD-L1 and not a PD-1, and that's something that could happen. So again, learning from these experiences and listening to some of the preclinical data that's developing, I think is going to be very helpful in figuring out where all of these new drugs go. I doubt that we're going to see another sort of a checkpoint inhibitor combination that's going to be, again, giving us these wild OS survivals the way we used to get. But I'm okay with making a little bit of a progress at a time. I will take a hazard ratio of 0.7 in a phase 3 study. Again, hopefully with a little bit of a better patient selection, a little bit of a biomarker selection. So I think we're going to be able to sort of make these advances gradually. And also, don't forget that you're concentrating on these checkpoint inhibitors and all that, but there's a whole slew of ADCs that are coming. There's a whole slew of bispecifics. The BiTE structures are becoming a reality in solid tumors. Yes, they do have toxicities and all that, but I think we're getting good at managing some of this and figuring out how to combine these drugs. So I think we have no shortage of pathways and drugs to sort of consider, but we got to do what Eddie said. We have to be careful, and we have to be more thoughtful, and we have to do the work to, again, find the right patient for the right combination.
Really great points, actually, and thank you also for that, for that last point about, checkpoints are one of more therapies that are evolving, and kind of where in the landscape is this going to play out. I may actually just take that, step into moving into, Hasa, actually, you'd mentioned ADCs, and I think that, prior to perhaps you joining, Eddie and I were kind of just talking about some of the avenues that we may speak about. And ADCs obviously is a big component in lung cancer. Kind of quite privileged because I know that you have done huge amounts of work on the ADCs. So I may actually just start with you, Husain, on that point is, can you give us like a little bit of thoughts that you've had, perhaps with some of the experience now with the TROP2 ADCs, areas of how you see ADCs playing out? Are they just going to be replacements for chemo? Do you actually view the side effect profile as being dramatically different than chemo? And is this just a different type of chemo that is evolving?
I don't think it's a different type of chemo, actually. I actually think ADCs have a lot of other advantages that, again, we are exploring in various studies. So let me take your questions one by one. Can they replace chemotherapy? I don't know. I think it's an interesting strategy. I've seen a couple of study designs where one cytotoxic chemo is being replaced with an ADC. And I think, again, in the context of investigating that as part of a study, that actually is not a bad idea. It can be replaced something. As long as that's something that we're replacing with, meaning the ADC, is actually a little bit more tolerable. I think what we're beginning to see is that unfortunately, the efficacy window that we wanted to see with the ADCs really is, it's a little bit better than it was 10 years ago when ADCs were gaining a lot of momentum and then they fizzled out. I think the current crop of ADCs have better linkers. There's better antigen selection, and so the antibody that targets the antigen is actually a little bit better. I think the toxins are somewhat better, although many of the older toxins from 10, 15 years ago are still being used, but the linker technology, I think, has had a lot to do with lowering the toxicity. So I think we're seeing some toxicities that could be because of the payload, but we're definitely seeing toxicity that could be antigen expression. In my view, and this is my view, the TROP2 antibodies that you talk, or ADCs that you talk about, with the 50-60% mucositis, to me, that's a target side effect. That's an antigen selection side effect, not necessarily the payload, because the payload is used in other ADCs and you don't get 60% mucositis. So we do have to be careful what antigens we select to sort of go after when it comes to the ADCs. So again, this is another area where I am hopeful that with the newer crop of ADCs and some of the newer platforms that companies are using to make these ADCs, we're going to reduce the payload toxicity, but the antigen selection toxicity is still going to be an issue that needs to be addressed. I am not happy with the 24% response rate with an ADC, although it is usually in patients who have had multiple lines of therapy. I think if we really want to find a home for these drugs, we have to do a better job of improving on the response and durability of response, and ultimately, obviously, the PFS and OS of all of this. So I think many of these ADCs remain a work in progress. You're going to have home runs like the anti-HER2 with really good activity in HER2 mutated lung cancer. And then you're going to have a couple, like, again, in my view, the TROP2 are going to be a little bit more problematic just because the toxicity is a little bit difficult to manage. You know, grade 2 mucositis is no fun. Yes, I understand the grade 3s might be low, but grades 1, 2 mucositis are still pretty painful and can affect the quality of life. So I think we do have to be careful how we sort of use these drugs in a general patient population.
You know, really great points. And I may just follow up, actually, someone was talking to me about ADCs, you know, earlier this week. The way that we kind of describe these is truly the medicine as a platform, you know, that really necessitates the right combination of antibody, linker, and payload. And there can be variations across each of those points. And now when one develops kind of, say, the optimal ADC, you know, may not be enough just to say that a cleavable linker in one construct may outperform a non-cleavable linker with a different payload and how we think it through. So it's really kind of a matrix, and really thinking about that. I think kind of probes the way we think about, you know, chemotherapeutic design. I think your points about perhaps the toxicities being different based on the antibody and how we think through this is important. I think there's considerations about you know, the DAR, so the drug to antibody ratio, as well as the cleavability of a linker. So a lot of complexity here. We'll actually just take this moment just to kind of show some of this data. And Has, you mentioned kind of that some ADCs have response rates in the order of about 20% after multiple lines of chemotherapy. May actually ask you, and this may seem just like a very basic question, but it's for my education here on this, is if an ADC is against a target, why would the response rate go down so much in later lines compared to an earlier line if that target was the real substrate that it was going against? It's almost like you give an EGFR TKI in the first line, or if you give it after chemo, you know, you still expect to have, you know, a high response rate. Like, why would the response rate go down so much after later lines?
Presumably because you've developed resistance to the cytotoxic payload.
Okay,
You're using the cytotoxic. Yeah.
So
So
it's resistance to the cytotoxic payload, not anything about, say, the targetability of the antibody or kind of the antibody specifically in terms of its goal.
so there are antigens that actually, so this becomes a little bit more involved, right? So there are antigens that can be recycled as you bind the antibody, this internalized and then recycled. And usually EGFR is sort of a classic, antigen that can be resurfaced and recycled back. To some extent, I think HER2 is like that. So there are some antigens that you really don't necessarily, in my view, completely lose them on the surface. It keeps coming back up. And then there are antigens that are known, although I don't think any of the current ADCs are targeting them, but there are antigen expression or cell surface markers that are expressed. And then with chemotherapy, with radiation, some of them with checkpoint inhibitors, can go up or down. So yes, if you choose an antigen that with prior therapy can have diminished expression, then you could potentially reduce the activity of the drug, knowing that many of these drugs also, at least theoretically, although again, I'm not a big believer of that, at least theoretically, they have some sort of a bystander effect that in preclinical studies you can sort of talk about or show a little bit. But I think, and unless Eddie and Aaron know, the primary reason for lower response rate is because you're using a cytotoxic, and if the cancer is already seen, so it's like going from first line chemo to second line to third line, your activity drops. I think you're basically observing the same thing here. Eddie, what do you think? Yeah.
I think there's also a tolerability difference, right? So capmatinib, for instance, which, capmatinib has a pretty significant difference in the response rate that's been shown in frontline versus second line. And some of that, is presumably tolerability issues that the unique thing about a drug like osimertinib is you can give it to somebody who's about to need to be intubated. And if you can get enough doses in, they're probably going to get better. And that isn't entirely an efficacy issue. It's a tolerability one. You can't do that with chemotherapy. And so I think it's probably some of both that play into to this issue. But the one place I guess I would disagree a little bit is, for me, a 25% response rate in a third line patient population, although not a home run, to have a 25% response rate in a third line patient population and a duration of response that's going to be around 10 months, pretty good. And frankly, that's better than what we had in the original early PD-1 inhibitor days. Now, that being said, the big difference, of course, is that we started to hit our 10-year survivors for the PD-1 inhibitors. And we don't expect that with this set of drugs. So to just count what's happening with the response rate in the median isn't a fair example. But I do think that those numbers are something to be excited about. And maybe when we do have those big home runs, we forget what our clinics were like. My practice started in 2006, and how different my clinic looks today than it did then. And that was from a string of home runs and a string of things that weren't quite home runs, but still were helpful. And so to me, the 25% response rate with a good duration of response, it still may be a double. It still can help and can still make a difference in your patients' lives. And so it's something about which I am somewhat enthusiastic.
Super helpful. And thank you both actually for this. I will, just in the interest of time, kind of just share a little bit of the design of one of the studies that was presented here. Again, this was a study presented by Benjamin Levy and the Tropion-Lung02. Basically, this was first line integration of an ADC, Dato-DXd, datopotamab, plus immune therapy with pembro. And I think that's an important point, really, kind of thinking through how are these agents going to be effectively combined. And actually, in this case, combined with platinum chemotherapy as well. So here actually, basically shows some of the design. The study was divided into different cohorts. Patients were, again, first line, less than or equal to 2 lines of prior therapy, and a variety of chemotherapy used in combination, whether it be cisplatin or carboplatin. Here actually just shows some of the demographics, again, across PD-L1, patients were included. Some prior therapies included immune therapy or platinum chemotherapy. And then some points, and actually this was what Dr. Borghaei had mentioned, actually some of the differential toxicities seem to be ones that included stomatitis. And, that is something that, we'll have to think more about. Interestingly, neutrophil decline in the doublet, again, in patients who were getting Dato-DXd plus pembro, looked a lot less than in the triplet. There was some cases of ILD, seems to be lower than with some other antibody constructs. And I may actually ask, kind of the group at this point, we have FDA approval now for a molecule, trastuzumab deruxtecan. Again, payload here, deruxtecan as well. In breast cancer, and in lung cancer, interstitial lung disease, an important component. Do we view there being some type of hypothesis generation about why we're seeing that ILD in different constructs? Is it not the payload? What do you think about that?
It's quite possible that there is some level of antigen expression. And in fact, I know that HER2 is expressed in lung and the normal lung. So it might be something to that effect, because the ILD rate in these, at least early going in these studies, is lower than what we see with the HER2 targeting with the same payload. So there might be something to it. But beyond that, just like the fact that I still haven't been able to explain why the drug works so much better in HER2 mutated lung cancer as opposed to HER2 overexpressing lung cancer. It's the same thing with the ILD. It's just one of the things that I haven't put a lot of thought into it, but I'm able to come up with a clear explanation as to why we don't have as high a rate here as we do with the HER2.
And interesting too that this combined PD-1, so that's just kind of an interesting point as well there.
Yeah.
But
the only thing I would caution a little on that, though, is that, datopotamab deruxtecan has been evaluated as a single agent. And in 180 patients, they did have three fatal events of ILD. So this is always one of the hard things when you're looking. Everyone will agree that a fatal event is rare. And hopefully over time, as we learn to treat these better and have greater recognition, the numbers will go down. Certainly that's what happened in the PD-1 inhibitor experience, is that the rate of fatal pneumonitis went down in subsequent clinical trials and was highest in some of the early clinical trials. But I think that this one study was reassuring, and obviously I agree it was in the context of PD-1, but it's not absolutely clear to me that the risk is not there. Now, there were all of the fatal cases of ILD were at a higher dose than is currently being developed. They're at the 8 milligram per kilogram dose. There's no further development at that dose. In breast cancer, the dose that's approved actually is less than the dose in the New England Journal article, looking at trastuzumab deruxtecan. So I just want to make sure that people are aware that there have been some serious cases with multiple different antibodies with the deruxtecan payload.
Super interesting. So just the final slide here is, I think kind of, this ORR seems quite interesting. In the doublet, 62%, and in the triplet, 50%, again, small numbers, however. And so we'll see how this plays out in a larger cohort. How do you guys reflect upon this? Do you see this as, a movement forward, and do you feel like, the avenue that this is going perhaps could be transformative in how we think through the disease?
I could add, we had this study open and I was really disappointed when it moved from second line only or second or later line to front line, because some of those responders on that curve are mine, and it was lovely to see some of these durable responses. So when this disappeared, it was really disappointing, because I had a handful of patients I was just trying to line up to get on here as they were coming off of the frontline therapy. So like we said before, although I didn't appreciate having my regional sports teams disparaged by Eddie, singles and doubles are okay too. But some of these patients have benefited well and have tolerated this well. Granted, the pneumonitis or ILD is a huge issue we need to sort through. But other patients have tolerated this really well and have nice responses. So I had this was one of my preferred trials for a little while.
I mean,
Aaron, I watched every game. They gave me a summer of entertainment, and there's always next year.
Yeah, there's always next year. They say that every fall.
I mean, Aaron, I may ask you actually, just because you have had actual experience with this molecule, in such what is it like? Is it easy to give? Is it, something that's challenging? Kind of what was your experience with this?
Yeah, and it's always anecdotal when you put, 3 or 4 patients on, and most of them had done well. Some minor cytopenias, which we typically call paper toxicities. But these patients of mine were, some were still working, to my surprise, very active in the communities yet. So I thought my patients had tolerated this well. That's my anecdotal experience.
That's
So
super helpful. Super helpful. And actually, I may ask you, this comment about my prior comment that is an ADC just another chemo. Now,
Yep.
Having experience with this, do you view it like that, or do you view it as kind of really something different than what we're used to with traditional cytotoxic?
Yeah, and I think my answer would extend beyond just these data here. There are other ADCs where I'm completely opposed to using, and after having had some of the drug development experience with them, I think those on-target, off-tumor toxicities can be severe and real, and the antigen selection is really difficult here. We have GTEx data, we've got tissue atlas, we've got things like that, but I do think you can have toxicity in healthy organs or healthy parts of organs with low levels of antigen expression that may not be widely reported or discovered. And I think of Rova-T, I think of anatimab and all the uveitis and visual difficulties patients developed. So I do think that the antigen select, all parts of an ADC are important, but some of these negative studies dampen my enthusiasm as much as like this one excites it. And there's some interesting thoughts where we've thought of these as maybe being the magic bullet where you get that better therapeutic index, but when you adjust for the amount of chemo that's added to the antibody, some investigators are arguing that the MTD is identical as the quote unquote naked chemotherapy, but you're just controlling where it goes. And if that antigen's on an important part of the body, you might be doing more harm than good. So that's where the real careful antigen selection, I think, is needed here.
Super helpful. And thank you so much for sharing your experience there. Unfortunately, I would love to kind of continue to carry on all of these discussions, because it's such a unique opportunity to kind of get you guys together in a room and kind of be able to have this discussion. I will perhaps kind of just have one concluding, ask is, perhaps kind of the last question that I'll ask, perhaps for each of you, is if you were to kind of place a bet on where you feel the most impactful new novel type of therapy to enter into lung cancer. And again, I'll give a list. And so a list actually may be antibody drug conjugates, novel checkpoint, TILs, and we didn't get to kind of discussing kind of some of these other cellular type of approaches in cancer as a whole. And then lastly, bispecifics. What would you say? And actually maybe, Eddie, I'll just kind of ask you, and then Hus, and then Aaron, kind of just a final point there.
So I'm going to refine your questions to a question I feel like I can answer, which is within 3 years, and my answer is going to be ADCs. I think that the horizon for the others is longer and will take more work. So I'm going to define it as 3 years, and then I'm going to say ADCs.
And I may just follow up and say, is there a specific antibody or
I think there's a lot more we need to learn. I think the one that, to be honest, the one to me that has the nearest term actually is the TROP2, just because of its widespread use across patients. So that would be. But again, I hope that there are higher heights that can be reached, but I think those higher heights are longer off with other approaches.
Okay, super helpful. Haas, actually, your thoughts?
I would have to agree. I think ADCs have a lot of momentum right now, so it's going to be hard to beat the ADC in the next 3 to 5 years. I do think we should keep some of the newer cytokine checkpoint inhibitor combinations that are coming up in mind. I think, again, it's one of those things that we're learning a little bit more. I think we have to learn a little bit more about the cytokines and some of the toxicities associated with them. I wouldn't say they're going to be ready for prime time in 3 years, like Eddie's timeline. But it is something that I would think in the horizon we're going to be talking about a lot.
Super helpful. And Aaron, your thoughts?
In terms of the horizon, I agree. I am excited by some of the cellular therapeutics, but also scared by some of the toxicities I see and some of the difficulties with getting them to actually infiltrate and kill the tumors. So a lot of work to be done yet, but excited by it nonetheless.
I may actually ask you just one follow-up point about that is, have you had experience with some of the cellular therapies like TILs or kind of such like that?
Not the TIL therapy, but with the mesothelioma population we see, and collaborating with the NCI, they've had some anti-mesothelin CAR T studies, and that there's I know of responders, but I know of I probably shouldn't call it hyperprogressors, but I know patients who've had no benefit also and have had cytokine release, hypotension, very difficult ICU stays, and it's difficult to see them go through that without any efficacy benefit.
Super helpful. Well, thank you all. Actually, really, it's been such an amazing experience to be able to speak with you all, and I thank you for your kind of insights here as we all kind of just reflect and think about the advances that have happened in lung cancer and kind of where some of them may happen over the next few years. So thank you again, and looking forward to the next webinar. I'll turn it over to Dr. Lashkari for some last thoughts. Well, actually, Dr. Lashkari, I think you're on mute actually now, perhaps. Yeah.
Thank you so much, everyone, for this wonderful discussion. I think we learned a lot, and I think we're all very hopeful in this area. Thank you, Dr. Husain. Thank you to our panelists, Dr. Garon, Mansfield, Borghaei. We really appreciate you guys. I know that you guys are on the East Coast, so so thank you for staying up late and being with us. Good night, everyone, and we'll see. And I want to finally thank our sponsor, Bristol Myers, for help hosting this webinar. We appreciate your support. Next month, we're going to be discussing small cell lung cancer. So that is very exciting, and we look forward to seeing you then. Good night, everyone.
Thank you.
Take care, everyone.
Thank you.
Thank you.